Well, thank you, and good morning, everybody. Just really happy to be here to share more about Rise Against Suicide and what we are doing locally here in Boulder and in Boulder County. So Rise Against Suicide is a Colorado nonprofit, and our mission is to help youth at risk of suicide by removing the financial and social barriers to treatment, enabling them to find hope and healing. And so our mission was really born from the fact that youth suicide still remains a pretty urgent problem within the whole state of Colorado, but also specifically within Boulder County as well. And so we were really born from the fact that we have kids who are self-harming, who have suicidal ideation, who just don't want to be with us any longer. And it's hard for them to access the appropriate services in a timely manner. Whether that's long wait times, whether that's mental health stigma within the home, whether it's their own personal shame and trying to hold on to their own level of dignity or their perceived dignity, that's where the barriers really arise. And I think one of the important pieces as well is really looking at, yes, there's a financial need potentially for kiddos to access care. It can be pretty expensive to receive some of these interventions, but we also have a lot of social barriers as well. And those social barriers really include, maybe some stuff going on in the home. Maybe there's peer pressure. A lot of these other pieces that are really important. And so that's why I always like to stress that at Rise, we really honor the Colorado state law where a youth 12 years of age and older can sign consent for mental health treatment on their own. And we do that to really ensure that we're honoring the rights of our youth, but we're also ensuring that they have the access that they need to stay happy and healthy and to get that hope. So thank you for letting me go off on that little tangent just for a second. But really how we support our mission, first and foremost, all of our services are free. And they're free for all youth experiencing some level of suicidality, 19 years of age and younger. We do not ask for income. We do not ask for insurance. We believe that this level of treatment and intervention for suicidal youth is life-saving and does not require any more barriers. So we're not going to ask any of those questions. The mental health care is a right for these youth. 2, our goal is suicide prevention, meaning we hope we get there before they're in full crisis. So I think oftentimes, even in the title of Rise Against Suicide, people focus in on suicide and they immediately think crisis. Kids in crisis, they have a plan, they're going to carry it out. That's not necessarily always the case in who we will serve. We're very much interested in those lower acuity kids as well, that are just exhibiting some other risk factors so that we can ensure that they receive the help that they need so they don't get to crisis. And I think the third point, which is a point of pride for us as an organization and something that we continue to try to hone and develop, is the fact that our kids are not on a waiting list. So we really see when a kiddo is suicidal, timeliness is everything. And so we do not have a wait list for kids. They can be seen within 48 to 72 hours, depending on their individual need. All right, so our model overall, I'm a social worker by training, and so one of the tenets of social work that I take very seriously is meeting our clients where they're at. Not only within the biopsychosocial sense, but the physical sense of where are they physically throughout the day. And so one of the things that makes our model work so well is that we've partnered with local school districts and have a signed MOU in which our therapists are able to go into the school during the school day and actually provide the therapeutic intervention right there. So then that again eliminates any transportation barriers. It also supports youth who maybe don't want mom and dad involved because mom and dad, they see them as a perceived threat. And so it just is really helpful in terms of going and being able to support Boulder Valley School District, St. Vrain Valley School Districts, our other private schools, and other community organizations as well. So that's one of the pieces that I love the most, is that we go to where the kids are at. We have a robust network of therapists. So all of our therapists are fully licensed within the state of Colorado. And they also have at least 3 years of experience working with suicidal youth. So we're really leaning into those experts. In addition, we currently have 35 local therapists who sign on with us, and we ensure that we have an array of representative identities. So we have bicultural, bilingual therapists. We have therapists who identify within the LGBTQIA+ community. We really try to ensure that we have therapists that look like the kids that we serve. We have seen quite an increase in the number of Latinx youth that we serve. Last year we served about 35% of our referrals were Latinx youth. And so we ensured to have those proper cultural aspects in place when it comes to our therapists. In addition, we also try to get different levels of modalities of care. So talk therapy doesn't work for everybody. And so trying to ensure that we have other modalities to really ensure that our kids can heal in the way that they need to heal is really important. So anything from animal-assisted, nature-based, leaning more into the somatics, anything like that to really ensure that we have a bevy of options for our kids. And then lastly, within our model, we try to use best practices as much as possible. We implement the Columbia protocol out of the University of Columbia or Columbia University in New York. And we worked very closely with Dr. Kelly Posner there, just to ensure that all of our therapists had the appropriate training that they needed, but then also that they were doing the real-time suicide risk assessments as needed. So the Columbia protocol is great for our therapists because it's like 6 or 7 questions, and they're very to the point, and it gives a very real-time assessment of like what is their risk of suicide, high, moderate, or low. And then that informs our therapist in terms of what the next step should be. Whether that, if it's really high and they're exhibiting some other really frightening risk factors, like maybe that means inpatient care right away. Or maybe if it's more moderate, really kind of creating that safety plan as it relates to the youth to ensure that they stay safe throughout the day. We do have a referral process. We have a really wonderful RMS system. It's a semi-custom build from Salesforce. And this enables each one of our partners to have their own username and password. So once they kind of do an assessment, suicide risk assessment on the patient or student, then they're able to go in and make a referral within our system. And within that system, there's also a list of all of our therapists, who's available, what are their specialties. And so therefore that particular counselor or medical professional can decide, oh, okay, well, I think that this therapist will be the better fit for our client. We also encourage them to let the patient and the family, if necessary, also have some input as to who they want, because right fit is so important throughout the therapeutic process. And all of our kids get at least 20 free sessions of care. So we pay our therapists directly on a weekly basis for the services rendered, and a kid and a family will never receive a bill moving forward. We also really lean into our therapists as the experts, in that if a kid needs beyond 20 free sessions of care, then we can work with that family and that kid to ensure that that continuity of care is continued and supported. So kind of looking at where we're at in Boulder and in Boulder County in the last year, We served over 400 youth, and we paid and funded over 6,000 sessions of therapy. So this is a pretty, the 400 youth, sad that it's an increasing number every year of kids who are deemed suicidal, but happy that we've been able to have access to them and they have access to us and the services that we provide. Within the funding, we have put incredible investment into our local school districts. So last year alone, within BVSD, providing over $350,000 of therapeutic support into the district alone. And that's all solely from our own funding and from our own generous donors. And that's money that BVSD wouldn't have had otherwise to support the mental health needs of kids. Happy to say again, I always want to root on our therapists and give them the biggest shout out, because without them, we wouldn't have a program. And so just really am so appreciative of the skills, the expertise, and the passion and dedication that our local therapists here in Boulder County provide to our kids day in and day out. They do, this is kind of a reduced rate that they receive. As a nonprofit, we only have so much capacity. And so, we're not paying them $150 to $200 an hour to work with suicidal youth. They get reimbursed at a rate of $90 an hour. And that can even be lower than some of the Medicaid reimbursement from the raise. So they're really taking this on as a passion project. And I'm just so appreciative and just always want to let our community know what our therapists are doing locally. Finally, we had in the last year 100% utilization rate. So that means once one of those 400 kiddos was connected to us, that they received at least one session of therapy, at least one contact with a full session. And that's something that I also we're proud of as an organization, because the utilization rate can be really tricky. You can provide all the support, gather all the resources that you think a family or a kid needs, and then there's no follow through. Or there's no action. And that's not a judgment on the kid or the family, it's just what circumstances provide. And so really, again, going to where the kids are at, whether that's at their school or otherwise, is key and really, really huge. One kind of final take, and please feel free to take a photo of my contact information. Happy to answer any further questions after this short presentation. But I think what's really important for us kind of moving forward is just getting the word out there that Rise Against Suicide exists. And we take everyone, fully inclusive, regardless of your financial status, regardless of your economic status, regardless of anything that's going on within your home and within your family. There should be no shame as it relates to suicide, and we need to be open and talking about it. And sad to say that it continues to happen. I know locally we had another attempt that we're trying to support as much as possible, but it's a real issue, and it's real, and it happens here, and we're here to help. So, thank you.
Any questions for Bill? Oh.
Yeah?
At what point do you find it necessary to bring in the parent or caregiver with the student that maybe otherwise wouldn't feel safe letting their parent or caregiver know?
Thank you for the question. Yeah, so if a kid really issues like an active plan of self-harm to themselves, like physical self-harm or self-harm to others, then we will pull in their guardian or parent to ensure that the safety plan is encompassed within the whole family, so that people can stay safe.
I have a comment and a question. First of all, I just want to say such a lack of support for teens with mental health issues. I'm really excited to hear about the work you're doing and going into the schools, and amazing, really, having 2 kids that just graduated from BVSD, such a huge issue, and we're trying to expand locally our services here as well, but it is very difficult to get teens mental health care. We should applaud you.
Oh, well, thank you. Appreciate that.
And then the question was, is this all donor funded? It's grant funded?
Yeah, great question. So a lot of our dollars come from private donations, local foundations. We also have 2 major fundraisers that occur throughout the year. So we do our Holiday Star program, which is a very much so a locally driven event, where businesses put up giving trees or starry walls, and on each one of the stars is a QR code to donate directly to our therapy fund. And so that's going to be coming up here starting in November. And then we do a local Emerge, our 5K run at the Boulder Reservoir every year. And that's really a way for us to generate community with those families who have lost a child to suicide. And so it's a way, it's kind of a sad way to kind of celebrate in a way, but it also provides a lot of hope and healing for families to come together. And that's in the first Sunday in May every year. So yeah, always looking to try to diversify, but that's kind of where we're at right now. Good questions.
Oh, yep, one more, hold on.
Hi, yeah, just a quick question about how do you get your name out there, and how do you get the Rise and your services known in the community?
Yeah, that's a great question, Mike. I think for our purposes, we've been really lucky to have, we're going to be doing more of like an advertisement. We had something out earlier within the community, but it's like posters on bus stops. There was something at the Flatirons Mall, 29th Street Mall, just kind of visuals, but it appealed more to youth. So if I had some examples, I'd throw them up there. But when the marketing team first showed us, I was like, I don't get it. I don't get what this means. And they're like, you're not supposed to. Like, you're a 40-year-old man. Like, you're not supposed to get this. This is for the kids. So we're trying to do more like visuals out in the community. We really lean into our school partnerships the most because that's where we get a lot of direct access to the kids. But really word of mouth, I think, works really well in Boulder. And that's, if somebody has a really good experience with us, that they're able to share that with their friends and families. But I guess to fully answer the question, Mike is just asking everyone here today and online to share about Rise and let people know that it's absolutely free, and we'll take anybody who has a youth who's dealing with some level of suicidality.
Could you speak a little bit more about the potentially varying degrees of receptivity you see from the different school districts in the state? And no need for specificity, but just generally whether all are equally welcoming or if you potentially encounter any resistance.
Oh no, I didn't want that question. Okay, so there are varying levels of receptivity. Like, there's different levels of people opening their doors to us, and some people being a little bit shyer, I'll put it that way. So not to name any names, but that can honestly go even by school. Different school administrators, yes, there's school policies they need to adhere to, but some principals have their own agenda and have their own comfort level as it relates to mental health as well. So we're always trying to work on our relationships, not only across districts, but with individual schools as well, in terms of how open they are to us. And that's even having a signed MOU. So it's interesting. Thanks for the tough question.
Oh, hold on.
One
hold
more?
on, come.
Okay.
I'm just wondering about parents, how you're reaching out to parents, because oftentimes kids might not disclose in school, but parents are struggling at home with the kids. What are different ways that you're able to reach them?
So we have a really amazing communication specialist now. I wish she was here because I could give her a big shout out. So our socials have gotten a lot better, and who we're connected to through social media, parent groups and the like has also improved. So definitely taking that angle, also trying to be out in the community as much as possible. We're a really small team, but we try to get out to a lot of different community events, to table, to let people know that we're here and that we're here to help. And I think at the end of the day, as it relates to parents, it's hard because they, as much as we want to support the parents in what their individual needs are too, our first thought is always going to be with their kid. And so leaning into the parents as much as possible as being the experts on their child, and really seeing how can we support you. We've talked about ways that we can further support the whole family. We will do, thank you for this question, we will at times do like a family session, or if the parents are involved, sessions with the parents and the kids. So we are flexible in terms of how we will hold space in sessions, because that's really important to have that holistic approach to include the family unit as much as possible. So I also want to stress that, like, as much as we honor the confidentiality of our kids 12 years of age and older, we also know how important it is to include the whole family. Awesome. Well, thank you so much for your questions.
And if you're not signed up for their newsletter, it's amazing. They give updates here and there. They give really great information on like who they're accessing, how many kids they're accessing, and just like normalizing this conversation about mental health and suicide awareness with youth, which is amazing. So definitely commend y'all. And then just trying to find it. Oh, there we go. Awesome. The wrong name is going to be up on the screen.
Yeah,
but I'll introduce
apologies.
myself.
Yeah, sorry.
Awesome. Well, hi, everyone. Good morning. I'm Jazmin Marguia. I use she, her pronouns. I am coming from the Office of Suicide Prevention. I always have to lower the mic because I'm 5'0". But thank you all. I'm curious to know who here in the room knows about the Office of Suicide Prevention in Colorado? Okay, beautiful. Okay, awesome. So this is going to be great. I'm going to be giving a lot of information about the Zero Suicide Framework specifically, but just know that the Office of Suicide Prevention touches a whole array of other programs and projects that we have at the state level. So it's coming from the Department of Public Health and Environment. So just want y'all to know that. Welcome any questions at the end as well. But before I get started into all of the information that I will be sharing, I do want to read this quote, and I do want us to kind of sit with it. So it reads, "Statistics are merely aggregations of numbers with the tears wiped away." So at the state level, we do see a lot of statistics, right? We see all of the numbers. It can go into the hundreds to hundreds of thousands of folks who do experience suicidal ideation and suicidal despair. And so we want to acknowledge that behind every single one of those numbers is a story, right? Friends, family, we've all touched suicide in some specific way with our own lived experience. And so just want us to sit with that and know that as I read all of these numbers and statistics, like that does not leave the philosophy and mission of the Office of Suicide Prevention. So the numbers, they do highlight preventability, recovery, and hope. Do want to share, and maybe this is something that you all are aware of as well, 90% of those who attempt will not go on to die by suicide. So again, highlighting that facet that folks do reach recovery and hope, are able to access resources, therapy, counseling, and all the work that you all do as providers. For every adult death by suicide, there are 3 attempts resulting in hospital admission, 8 attempts leading to an emergency department visit, 38 attempts that are not medically treated, and then 265 people experiencing thoughts of suicide. And these are the exact folks of people that we are trying to reach at the Office of Suicide Prevention, whether it be through our newsletter or provider training that we provide free of charge to you all as clinicians, and also non-clinician staff working in healthcare, behavioral healthcare settings. I do want to share that at the Office of Suicide Prevention, we do take a comprehensive approach, and it is guided by these 6 pillars up here. We know that suicide is complex, and it's not only solely about mental health, but it's all about all these other facets in our lives that keep us thriving, right? So we discuss connectedness, economic stability and supports, right? How are you financing your life? How are you making a living? That is super, super connected to just how you feel connected in the community. Education and awareness. So again, for clinicians, non-clinicians. Access to safer suicide care, which I'll be talking about today. And then lethal means safety and postvention. Who here has heard about lethal means safety? Okay, a few number. Awesome. So that's one thing that we also try to highlight a lot at the Office of Suicide Prevention is this concept, right, of lethal means safety, whether it be accessing guns, medications, prescriptions, right, all these methods of suicide, and trying to train folks, right, on how to counsel folks on how to be safe when they do have access to lethal means and how to get them to a safer place, right, and do that time and distance to lethal means. In these bullet points, it is not super comprehensive list of all that we do, but just a little bit of highlighting kind of the major projects that we do. So we do have a suicide prevention commission. It is bill mandated, bill funded, I believe, at the Office of Suicide Prevention. And we have 26 folks who sit on this commission, and they vary from clinical experience, lived experience, coroners, and a whole variety of priority populations as well. If you are interested in knowing more about that, we have more on our website. The Colorado National Collaborative, it is I guess they take more of this pillar approach in the work that they do, and it is a variety of counties who are grant funded to do suicide prevention, intervention, and postvention work across the state. They do amazing work, and they're held at a national level, hence the name. I oversee the follow-up project, and if you are not aware what the follow-up project is, you'll definitely know today. I'll share more a bit later, but just know it's about carrying contacts to folks who are discharged from an emergency department or inpatient psychiatric unit, all free of charge to hospitals and to patients alike. Gunshot project, so right, again, that concept of lethal means safety, letting folks know what safe storage means, and time and distance again. And a whole bunch of federal grant funding that we do within the office as well. A little bit more about our comprehensive approach. 100% of our available federal grants do go towards our efforts in suicide prevention, intervention, postvention in Colorado. These numbers could probably be a little bit more updated, but we have updated more than we have trained more than 9,500 folks in suicide prevention, education, and awareness. A little example of how we collaborate with key partners, so 12 agencies that are partnered with the Gunshot Project, and then we have funded through various modalities of funds, 14 school districts for comprehensive crisis and suicide prevention training strategies, one of those being Sources of Strength. Not sure if y'all have heard about that or are knowledgeable on it. I see some head nods. But Sources of Strength, right, the strength-based approach to building that connectedness amongst youth in school settings. And then lastly, we do operate on a health equity lens, so we do provide statewide recommendations from the commission into all of our projects, right, based on priority populations, such as BIPOC, so Black, Indigenous, people of color, and then LGBTQIA, Two-Spirit plus youth and young adults, to veterans and older adults, and then high-risk industries as well, which we see more of that higher risk of suicide despair. So a little bit more about providing safer suicide care and why we do it. We know that in the month before a patient's death by suicide, 50% have seen a general practitioner, 30% saw a mental health professional, and then 10% were seen in an emergency department. We know that what brings an individual to this experience of suicidal despair is incredibly different, variable, and individualized. Again, we know that it's super complex, and it can be various experiences that can bring an individual to this experience. So Colorado's approach for improving access to warmer, safer suicide care, that is through our Zero Suicide grant, or the Zero Suicide framework. I'll have a QR code so y'all can kind of like scan that in the next slide. But that is a framework, right, a health system framework that develops kind of this integration of a culture change to policy change to provide that safer suicide care within health systems, and making it not just like normalizing the conversation of mental health, but also within the staff and worker well-being and all of that. I oversee the follow-up project again, a strategy and postvention that we deliver and provide at no cost to hospitals across the state, and all of the patients that we have done. And this project has been active since 2018. I started my role in 2022, but I feel like I've just like worked with it since its inception, and I think it's an amazing project. And then some stuff that has been mentioned under HCPF is a hospital quality incentive program. Raise your hand if you're familiar with it. So kind of like those incentive quality points that health systems can deliver better strategies, right, for their healthcare quality. So a little bit more about the Zero Suicide Framework, which I think is amazing. It is a flexible quality improvement framework for Colorado healthcare organizations. It is an aspirational approach. It has 7 tenets, which I'll talk about in a bit. A national priority for suicide prevention. So again, if you're familiar with SAMHSA and the grants that they deliver, this is a Zero Suicide grant, and so we get funding from them to deliver some mini grants or sub-grantees their own starting off jump point, right, with the Zero Suicide Framework. And it is a just, blame-free, and stigma-reducing culture change above all. Health systems implementing the Zero Suicide Framework have seen up to an 80% reduction in the suicide rate amongst patients receiving behavioral health care. And it is because we have so many strategies and so many objectives within this grant, which I'm sure some of you may know and familiar with grants and how they work, all of the strategies that are implemented to enact it. So some of these 7 priority areas are leadership commitment. So we know that without that leadership commitment to provide a culture change, it's just not going to happen, and we need to have that kind of example setting from there. And we need it to also center lived experience. They do have steering committees that involve a variety of community members within each health system. We have 8 grantees this year for the next 5-year cycle. And so they have each individual 8 steering committees across the state. The second one is identify with standard screening and safety assessment. So again, the CSSR screening and a bunch of others as well. We know that we have to engage with the suicide care management plan, so oftentimes also referenced as a safety plan. Training and developing all staff, right? So leveling up those competency spaces and areas. A lot of the time when I ask folks, like, are you comfortable asking the question if someone is planning on dying by suicide or planning to kill themselves? Oftentimes, behavioral healthcare folks say, yes, I'm super comfortable with that. And then we go to practice it, and it's like, right, this nervousness. And so that's something that we try to implement day by day within this grant, just a small example of developing that normalization of having this really, really difficult, tough conversation. 5th is right treatment with effective evidence-based and culturally responsive treatment. At the Office of Suicide Prevention, we do provide training for free, so if y'all are ever interested, AMSR, not sure if y'all have heard of that, but assessing and managing suicidal risk, and then BCBT, brief cognitive behavioral therapy, specifically for suicide prevention, and a whole bunch of other ones as well. Follow-up during transitions, so this meaning that hospitals can either do the follow-up project that we have at the Office of Suicide Prevention, or do their own caring contact follow-up internal to their own organization. And I'm sure some of you may be familiar with that within your own practice of providing follow-up caring contact. So literally a postcard, a phone call, email, text, whatever that looks like, to just show that patient, hey, I'm here. I'm not necessarily asking you to show up to your appointment, but know that I am here, and we're here together to collaborate on this accountability together. And then lastly, as we all know, assessment and data collection is super important to the work that we do. And so this ongoing quality improvement framework is what we operate each year. And you can read a lot more details about that on that QR code to the Zero Suicide Framework. There's workforce surveys, so if y'all want to implement that on your own staff, I know that surveys are a lot, but it is really great data that you collect to know just how comfortable your staff is, even from the front desk staff, to know how comfortable they are in even discussing mental health crises, suicide, suicidal ideation, and just what that looks like overall with competency as well. So we know that the zero suicide culture change, it goes from assessment to genuine connection and intentional conversation, right? From that space of fear to curiosity and hopefulness, and then from coercion to choice. Something that we emphasize at the Office of Suicide Prevention is that in all of these treatment modalities and all of these screening and safety plans assessments, right, if the patient is not consenting to their own treatment, like that is the most important thing to have. One of the things in the follow-up project that we also highlight is that they can only enroll if they consent. So they cannot be just because they're automatically discharging from an emergency department or inpatient psychiatric unit, you don't just automatically enroll them, right? They need to know that someone is calling them and they need to be ready for that phone call as well. So a little bit more about where we are at with the SAMHSA grant. That should say year 2 out of 5. We just entered year 2, and we're currently reading all the numbers, seeing how many folks have been trained, how many policy changes have been happening, and the lovely EHR, EMR systems that we all love, how those have been updated to integrate the safer suicide care, from screening to safety plans to even just like counting the number of folks who do, right, experience suicidal ideation or despair in our health systems. In our last SAMHSA grant, which was another 5 years previous to this one, we trained more than 3,500 staff and gatekeeper, or now we're saying community helper, suicide prevention trainings. We've trained more than 1,800 people in counseling to access of lethal means, so that's CALM, and then safety planning, and then 905 in CAMS. Who is familiar with any of these that I just mentioned? CAMS, CALM, ASSIST maybe, MHFA, mental health first aid. Awesome, beautiful. We provide all of those, again, free of charge. I'll have more information on that later. And then we also provide statewide support and technical assistance via academies, so national or state academies, workshops, ongoing education. Through our own Zero Suicide Colorado Learning Collaborative, we meet on a monthly basis every third Thursday or last Thursday of the month. If you want to be added to that, just reach out to me, but we highlight a lot of different topics and subjects within suicide prevention, intervention, postvention. And then lastly, health equity lens, also integrated in the work that we do through the Zero Suicide Framework. We know that treatment has to be culturally responsive, and then suicide-specific healthcare can help all our communities thrive. We provide an all-hands-on-deck approach, so through 2 staff training opportunities. Many are on demand again, free, no cost to you, mental health first aid, living work start, and these can all be found online as well. And then free on-demand counseling to CALM, safety planning, AMSR. So again, assessing and managing suicide risk. This is an 8-hour full day training. It's outpatient, inpatient, and substance use disorder settings that we provide training on. And those are scheduled, I just scheduled them, actually, one in December and then the rest in 2025. And then we also have provided in the past Columbia Suicide Severity Rating Scale trainings with Dr. Kelly Posner, which have been received with really great feedback. And then brief cognitive behavioral therapy for suicide prevention. Those are also scheduled now for 2025. So get on our newsletter to save your seat. Again, no cost. And then CAMS, it is a therapeutic framework to be utilized with clinicians. It is a collaborative assessment and management of suicidality. I know that the Hope Institute just opened here in Boulder, so definitely reach out to those folks. They have amazing training in CAMS and they partner with them, so definitely suggest that too. A little plug for them. This is just a little bit more of the technical support that we provide through OSP and the Zero Suicide Grant, again, with our 8 grantees, so one-on-one meetings, implementation teams, resources of policies, and then just like really a network of other folks doing the same work. And they can come and discuss challenges, barriers, and build that connection, connectedness through them as well. Lastly, I want to talk about the follow-up project. Who here has heard about the follow-up project at all? No? Okay. So the follow-up project, and it makes sense, this is for emergency department and inpatient settings. So again, they provide a vital support during a vulnerable time for patients discharging after receiving suicide-related care. This project is open to folks who have experienced suicidal ideation, self-harm, overdose, regardless of intent. And we've touched 75 health systems across the state, again, since 2018, and have served more than 25,000 patients who have discharged from an emergency department since then. And honestly, probably more because we utilized Excel back then and not the best strategy for keeping up with numbers. But it was housed under Rocky Mountain Crisis Partners. If you all are familiar with them, they were a nonprofit who provided excellent and amazing care for folks experiencing any type of mental health crisis. It is now going to be housed with CU Anschutz School of Medicine, led by Dr. Scott Simpson, Vicki Manley, and Nina Breathwaite. And so that is where the follow-up project is moving into. If you are curious to want to learn more about that, we'll have a webinar this upcoming Friday. Reach out to me or scan the QR code to stay updated on what this project looks like and how it's going to develop in the next coming months. But that is a lot of information and not even a tenth of what the OSP does. If you do want to learn more, there's the website. And yeah, I'll take any questions, curiosities, but thank you for your time. Yeah.
Questions? Okay, coming. Excuse me. Excuse me.
Hi.
Hello.
I'm Elisa. I'm with Primary Care Behavioral Health at BCH. And my question is, there were some numbers, I think on the second slide, regarding, let's see. Yeah, some of these data points. I was wondering what the sample size was for these numbers.
That I can email you later. I don't have it on me.
Perfect.
Yeah.
And thank you. These programs are excellent and great to know about the ones I don't already know about.
Awesome.
Thanks. I wanted to just comment about that follow-up project. Yeah. So I'm the chief medical officer here at BCH. And so occasionally I hear about patients who leave the ER with suicidality and they are not admitted. So they're sent home and I think it's probably rare, but they get this impression I'm not sick enough to be hospitalized, good luck. And so what we're trying to do is improve that follow-up, and I'm just thinking that we could connect a little bit more with some of the resources your follow-up project has, and maybe we're already doing that. But it sounds like there's some resources from the state that could help with, follow-up. It seems like a real concern for patients. The ER is not really the place for non-emergent behavioral health issues, and I think as some of our insurance folks were talking earlier, the follow-up is not straightforward. It's not very easy to get folks followed up. So if there were ways that other systems are doing really well at making sure these folks are getting a reach out, or it sounded like maybe there's cards you could give patients that would help them get, we'd love to sort of learn more about that.
Yeah, 100%, right? Yeah, because suicidal ideation, right, it runs the gamut, right, of acute to not acute, and so knowing exactly that follow-up care sometimes can be very, very helpful when it's just carrying contact to folks, and sometimes they do need that hospitalization. But this one is very, very specific to those who are discharged from the emergency departments. But yeah, would love to connect. Any other questions? I know it's a lot of information, and I talk really fast as well, so I apologize, but it's all great information, I think. Yeah. Oh, back there.
So it's more of a comment. In 2017, I had an attempt, and I was in a rural city of Durango, which I actually saw on the follow-up map. But at the time, I don't think any of that was implemented. Yep. And after my attempt, I was left on my own, and I had to, navigate, what happened to me by myself, without follow-up, without people reaching out. So I just wanted to say that I'm really happy that this is here and that other people don't have to go through that by themselves and that there's other support around. So yeah, I just wanted to say that.
Thank you for sharing that. Yeah.
Thank you for sharing.
Yeah, the follow-up project definitely came from, as I mentioned, the commission. They gave a recommendation back then, 2016, 2017, started as a pilot project in Denver Health, and then has now grown to 75 hospitals. I think the pilot was like 15 sites, and yeah, has grown to 75 hospitals, and has just been an amazing resource to folks, because it is free of charge, right? Free of service to hospitals and to patients alike, and so they just need to pick up the phone and receive that caring contact. It can be a conversation from like 15 minutes, right? A 15-minute check-in to an hour if they need it. And then obviously following those best practices within follow-up care too. I think we had a question up here.
I'm just wondering what the trends are that you've seen in suicide over the years, like in the last 5 years. Is it going up, down? Are there certain groups that are more at risk?
Yeah, there's definitely more groups at risk. I know within Black youth, that has definitely been a population where we've seen a higher risk of folks, and obviously we can run the generalizations, all of that, with what we've seen nationally with the Black population, Black communities, and what we see nationally with racism and all of the isms. In terms of Colorado, I think rate has stayed steady, declining. I know Larimer County, the youth rates have been declining. In terms of more trends, we do have a national reporting system online somewhere, which I can provide all of those resources later, where you can see more specifically like what that looks like as well. But yeah, there's so many trends out there and so many statistics that I would be out here giving like another presentation. Yeah, thanks. Cool. No more questions?
Any last questions, thoughts?
Great, well, thank you so much for your time.